All right, we're going to go ahead and get started with the second part. One more time, I just can't thank Dr. Prajna enough for taking the time not only to fly nearly 12 hours of time zone difference away, but also for delivering 3 hours of what were very informative and also very inspirational talk. So thank you so much. My name is Brent Finklea. I'm the director of the Center for Global Ophthalmology. And this is our annual Paton Lecture, which is in name of David Paton. And so I know that Dr. Prajna gave a brief history, so I won't linger on this too long. But David Paton was a big supporter of global ophthalmology, and in particular that which was being performed here at Wills Eye. He provided us a substantial sum of seed funding back almost 10 years ago now, which allowed us to start this department. And so in his honor, we like to remember that contribution every year. He was born back in 1930, graduated from Princeton, Hopkins School of Medicine. He did his residency at Hopkins as well. He later became the chairman of the Baylor College of Medicine. As mentioned, he was the medical director of the King Khaled Eye Specialist Hospital in Saudi Arabia. And he went on to become the chairman of the Weill Cornell Department of Ophthalmology. He's founder of Project Orbis, chairman of the ABO, and the first vice president of the Academy of Ophthalmology, American Academy of Ophthalmology. Countless awards and recognition, really a highly decorated career, and he gives his apologies for not being able to travel this week to join us, but I know that he's also watching. So hello, Dr. Paton. Thank you again for all of your generous contributions. So very in brief, I'm just going to go over what our department has been working on this year, and then I'll turn this over to our fellow. But for starters, I'm going to highlight a few partnerships which have developed over the past year. Of course, one of our most long-standing partnerships is with the Rwanda International Institute of Ophthalmology. This is Dr. Chiku Matenge, who is the director of their programming, along with her husband, Dr. John Nkurikie. They've been our partners back since 2016. 2 years after that, they established the residency program, which is now in its fourth year. They have 14 residents over those 4 years, and they come from 4 different African countries. They have vast support both from academics around the world and also from a number of different organizations. And they've become a highly successful training program with exceptional pass rates through all of the international examinations. And I can attest that the quality of residents that they are graduating are really outstanding on an international level. Our faculty travels to Rio on a regular basis to support a grant by the Senior National through the Links Foundation and the London School of Hygiene and Tropical Medicine. We like to provide academic support. We do grand rounds, we do journal clubs, we teach in clinic, and we provide surgical support. This year, a few highlights for the program. Also, they hired their first full-time non-Rwandan employee who hailed from Nepal. And then we're also seeing our own Dr. John Cropsey, who will be moving permanently to Rwanda as of July of this year. I think actually next month they'll be moving. And so we're looking forward to a continued collaboration with Rio and all of their partnerships. Additionally, in northern Ghana, I'll say an expat from the States, Judith Simon has opened up a hospital where she's been working for about the last 10 years. Last year with Dr. Omer Ali, we formed our first partnership with her to begin an SLT training program and project, which is supported through a grant from the UK. This continues to evolve, and this next year we have our fellows traveling to work with her again on this SLT project, as well as other laser interventions throughout the country and specific training programs. She's really doing exceptional work. Our newest program this year is with Medical Ministries International Peru. This is a long-standing outreach program by Medical Ministries International. Over the last 2 years, they've started to develop a more sustainable model, which involves hiring of local providers and also establishing a stationary clinic that is there year-round. At this point, they have 2 full-time ophthalmologists and 2 full-time optometrists and 1 part-time ophthalmologist. And our goal is to help to expand their clinical offerings, help to do training with the staff and all of the new equipment that they received through a donation this year. Our fellow, Dr. Eliza Barnwell, traveled this year to basically help set up the clinic with all of the equipment that they received and to start training the staff on all of the diagnostic equipment that has not been present so far. Additionally, the city of Arequipa, which is the second largest city in the country, but has a significant health disparity due to only 20 ophthalmologists practicing in the city and none in the surrounding region. we're working to try and incorporate the residency training program into their initiatives so that ingrains them more thoroughly into the local ophthalmic community and the medical community as a whole. Last year, we started the Access Clinic, which is a domestic clinic down in South Philly at the Bach Building. This is in partnership with Jefferson Hospital. It's been open for just over a year now. We call this local eye care because we're looking for our international citizens that are living here in Philadelphia. This includes our refugee population, our undocumented immigrants, and other individuals who have not been able to receive care due to either location, coverage, or language barriers. We received very generous donations from the Harley Foundation, the Lurie Foundation, and also I have to mention Reed Kinderman personally from his clinic to get this up and running. And we're looking forward to expansion of this project as time goes on. We're currently running this clinic every other week, and we're seeing patients from a wide variety of backgrounds, most particularly West African and Southeast Asian. And so one of the big challenges that we are working through are language barriers, which our exceptional medical student team has helped with developing multilingual handouts and also different forms of telecommunication in the clinic. The clinic is basically part of the primary care clinic, and we consider almost our own little remote clinic that will pop up in their community service space every other week. We do comprehensive exams, we do eyeglasses, and I also have to give a big thanks to the Will's Eye Optical Shop, as they have been donating free glasses to patients who are seen and screened down at this clinic and given their own prescriptions. And so a number of individuals have benefited from this program. And again, I have to say that this program wouldn't be possible if it wasn't for, the very generous time that's been offered by our KGO faculty. I have to say especially thanks to Dr. Ali for his time and commitment to this project on a continuing basis, but also, very importantly, our medical students. I consider this a medical student-driven initiative, as this is something that they have really taken under their wings and they have made flourish. Our medical students not only do outreach to the other community service clinics in the area, they also manage patient flow, they schedule patients to be seen, they do follow-up scheduling to make sure that those patients who have diagnosed pathologies do follow-up at Will's in the appropriate clinics. And I have to thank our clinics here for also absorbing them into the workflow, usually for low or no cost, depending on the patient's background. The WIRE program. So the Will's International Residence Experience, this is our 10-year anniversary this year, as it began in 2012. We've had nearly 50 residents who've spent time at least 1 to 2 weeks abroad over the past decade. This is in a variety of countries across 3 different continents. And we are so glad that after a 1.5 year hiatus due to COVID, we are finally able to get our residents back into the field. And so we'll be hearing from 2 of our residents this year who were able to travel to Morocco and to Kenya and get this project up and running again. What we really find valuable about this program and what Dr. Prajna brought to light is, while we can spend our time in clinics here in the States and we can understand the methodologies and workflows that we see, there's so much that can be gained not only just from the patient care directly in other countries and in other healthcare systems, but it really broadens your eyes as a trainee and as a young provider into ways that you can augment your own clinical practice to bring better care, make note of lower cost care to help the healthcare system as a whole, and also meet patients where their needs are the greatest, which is not always truly in the diagnosis and treatment itself. And finally, the International Scholars Program. Again, this has been closed for the past 2 years, but we are excited to get this program up and running. This is a program where we bring young physicians or even established physicians from other countries to Will's for any sort of observerships lasting from a few weeks to a few months. We've been so grateful to have outstanding colleagues that have formed lifelong partnerships in other institutions, and we're very excited about our potential collaborations with Aravind in the future. So thank you so much for going over our department's happenings over the past year, and I'm going to bring up Eliza Barnwell so she can talk about her fellowship year and some of the work that she's been doing with our partners.
All right. Hi, everyone. My name is Eliza Barnwell. I'm the current Academic Global Ophthalmology Fellow, and I just want to give a thank you to Dr. Prajna. Thank you so much for coming here and giving those insightful talks. I really learned so much about Erevan, and I really would love to go to Erevan someday. So this year I've had the opportunity to travel for about half of the year and spend about the other half of the year in Philadelphia. And so I want to talk about the experiences that I've had this year, where I've traveled, and what I've learned. So one question that I've gotten a lot is why pursue global ophthalmology? And it's not just for racking up a bunch of air miles, though. I do enjoy having gold status now with American Airlines. But I've really had a chance to work with some leaders in global ophthalmology, including Dr. Chiku Muthinge, who's the founder of the Rwandan International Institute of Ophthalmology. And she has said many wise things, but one thing that stood out to me is that we are all in the same race against blindness, but we are running in different lanes. As ophthalmologists in the United States, we have incredible access to equipment, technology, and resources, and I think we just don't realize how much we really have, and there are other places that simply don't have access to these things. According to WHO's recent World Report on Vision, there are at least 1 billion people living with vision impairment or blindness that could have been prevented or has yet to be addressed. And 90% of those affected are living in low and middle income countries. And this slide is just breaking down that 1 billion number. You can see the top two causes are unaddressed refractive error and cataract, and these are causes of blindness that we know have cost-effective interventions. So really, the goal of global ophthalmology is to make the same high standard of eye care that we have here in the U.S. Available to everyone in every place. And it's a lofty goal, and how can we accomplish that? And as an ophthalmologist from the United States, one of the biggest impacts that we can have is by strengthening resident training programs in low and middle income countries through education. And that was my first mission right after I took my ophthalmology board exams. I was full of ophthalmic knowledge and traveled to the small country of Rwanda in East Central Africa. And Brent already talked a little bit about our partnership with RIO, the Rwanda International Institute of Ophthalmology. It's one of the newest and most reputable training programs in East Africa, the only training program in Rwanda for residents. It was founded in 2011 by Dr. Chiku and her husband John, who's also an ophthalmologist, and then they had their first resident class start in 2018. There are 14 residents total. The first class is graduating this year, so it was really nice working with the whole group this year. And most of the residents are from the country of Rwanda, but some of the residents are also from nearby countries of Burundi, the Congo, and Kenya. And my role was really with clinical teaching. So I worked with the residents in the clinical community clinic, and we did lectures every day, and just did a lot of things in clinic with the residents. So the picture on the left is showing the patients ready to be seen in the morning. And then in the middle is me with a group of the residents. And there was a teaching scope, so we really got to do a lot. And then we had wet labs. So this picture is from a Saturday after doing some suturing on pig eyes that morning. So it was really just a fun bonding experience with them. And the nice thing too is my trip there was a give relationship. I went there to help teach residents and help them with clinical skills, and then I also was able to participate in some surgical outreach trips. And this is a trip, this picture is from a trip we did with Dr. John up to the northern part of Rwanda near the Ugandan border, and did manual small incision cataract surgery, and he helped teach me some of the steps of that surgery, so it was really an incredible experience. So I got back to Philadelphia and was home for Christmas, and then after New Year's went on my second trip of the year, which was to India, and went to the LV Prasad Institute in Hyderabad, India. And we heard so much about Aravind today. Just a little bit about LV Prasad. It was established in 1987 as a non-profit, non-government eye care institution with a mission to provide equitable and efficient eye care to all sections of society. And incredibly, since being founded in 1987, they have served over 32 million patients in over 200 vision centers, 50% completely free of cost. And they have also trained nearly 40,000 personnel. So being at LV Prasad, it was incredibly busy. They see so many patients. My main role there was to take a course. I took a manual small incision cataract course for 1 month, and it was just such a great experience being trained by expert surgeons who've done thousands and thousands and thousands of these cases, and they sat with us and taught us the step-by-step of manual small incision cataract surgery. And you also really form a bond with the co-trainees. This is the picture in the middle with some of my co-trainees. We spent, all day together, and it was just nice having that camaraderie as well. And one other thing I learned in India is not to go for a walk in parks, because I came across this sign and never went back to this park again. So I'm still not sure what that means, but it's not good. So I came back from India with all this great knowledge and had an experience, and then was in Philadelphia for a little while, for a couple of months before my next trip to southern Peru, to the city of Arequipa, and worked with an organization called Medical Ministry International. It's a nonprofit organization working in 22 countries with the goal of increasing access to affordable quality healthcare. And MMI Peru has really taken on a mission with eye care, and they now have 3 full-time optometrists, 1 part-time ophthalmologist. They have an office space for seeing patients, as well as a mobile eye unit that they take to the surrounding areas of Arequipa and further out to more rural areas. And they're really doing a lot. They have surgical campaigns. They were having surgical campaigns once a year, kind of got stopped with COVID, but that's coming back this July with a group of ophthalmologists from the United States and Canada coming to do mainly cataract surgery. So my role in Arequipa was, for one, to help establish a relationship with MMI and Will's Eye. I was the first fellow coming to Arequipa, so I was just working with the organization and understanding what they do. They received this amazing donation from 2 retired ophthalmologists in Canada, and I got to help set up some of that equipment. You can see in this picture, it's a really nice OCT machine and corneal topography and a retinal camera, as well as a Humphrey visual field. So they have all this great equipment, and while I was unpacking the boxes, I realized that I actually know the ophthalmologist personally who donated the equipment, and I'm friends with their daughter. And I had no idea that they were the ones who had donated everything. So that was really kind of a small world moment. And after kind of helping set up this equipment, another role was working with the optometrist so they could understand how to use it and understand how to interpret the results so that they can continue to use all this great equipment on a daily basis. I did some office consults in this nice office they have, and then we also took the mobile unit clinic kind of out basically drive out to the outskirts of the city of Arequipa and see patients. And we took 2 trips to more rural towns, one about 5 hours away and one about 3 hours away, to places where patients really needed eye care. I had the chance to visit some local hospitals and got to meet the residents in Arequipa. There's a residency program there, and that's something that we're excited about, is getting wills involved in the future with the residency program. And also did a pilot study, a survey study on the population of patients we were seeing. So I'm going to spend the next few minutes just talking about that study and the results from that. So just a little bit of background. Peru is a middle-income country with historically vast inequalities between the rich and the poor. Arequipa is the second largest city. It has a little under 1 million inhabitants. It's a dry, sunny climate, 2,300 meters above sea level, so it's pretty high elevation. And many inhabitants live below the poverty level, particularly in the outskirts of the city. This is a picture. You can see just how dry the climate is, and there's a lot of dry eye. So the aim of this project was to assess factors associated with eye care service utilization and barriers to care in this population that were visiting these mobile clinics in peri-urban and rural areas surrounding Arequipa, Peru. And just want to mention too, the model that MMI has, they want to really make it sustainable, so they do charge patients a small amount. It's only about $1.50 for the visits, and then when they prescribe glasses, they're able to manufacture those glasses at a cheap cost, around $5 for the pair of glasses. So it's not, they're not giving free care, but it is trying to be like an affordable model for these patients. So for the survey study, we had an interview-based questionnaire that was developed in English and translated into Spanish. We used that to collect the data. And the interviews were conducted in Spanish by a native speaker on the same day as the patient's eye exam. So we saw a lot of patients, but could not survey everyone just because there had to be someone available who could do the survey for us. We obtained informed verbal consent prior to participation, and then asked participants questions about demographics and socioeconomic status, as well as any history of prior eye care. So there were 142 survey participants, the average age being 59, ranging from 18 to 91. 44% of the participants were 65 years or older. There were 88 females and 54 males. And for those who answered this question, the average salary per month per household was 818 soles, which is over $220 US. 101 of the surveys were from the urban area surrounding Arequipa, which is right here. And then 41 of the surveys were from the rural towns of Shabai and Wambo. And this is just a map so you get an idea of where that is. This is a picture of the town of Wambo. It's very small. It's in an area called the Colca Valley, which is beautiful, but very, very rural. So out of the primary diagnoses listed on the patient's chart, the most common primary diagnosis was refractive error presbyopia, followed by cataract, pterygium, and then macular degeneration or atrophy, and then dry eye blepharitis. So those were the top primary diagnoses. And just kind of looking at the difference between urban and rural, there was more kind of refractive error being the primary problem in the urban population. The rural population had a little higher percentage of cataracts and macular degeneration and kind of things that were more pathologic. And what was kind of interesting to me is that actually 67% of the participants did report having history of a prior eye exam. So a lot of them had been seen by an eye care provider in the past. The average time since the last visit was 3.5 years. And 70 of those participants endorsed having prior eye treatment, most common being glasses. And 7 of the participants stated that they were told that they should have surgery, but they were not able to obtain that surgery. Several of the patients said they weren't able to have surgery because of COVID. And for those who'd had treatment and had reported on the cost of treatment, that average cost was around $74. And when just looking at the ones who reported on the cost of glasses, they spent about $35 on glasses, and a lot of them had said that their glasses had broken and they'd not been able to replace them. So 84% did say that they were able to afford the treatment, but 43% stated that they were not able to continue whatever treatment had been given in the past, though, and 65% said that they were either satisfied or very satisfied with the prior eye care that they'd had. So looking at the other side of that, 33% had said they had no prior eye care, and the most common reason being they just had not needed an eye exam in the past. But some of the other reasons was that the service were too far away, or that they weren't able to afford it, or that the service was not available at a convenient time. So we're definitely seeing that there were some barriers to receiving care in this population. And kind of looking at the visual acuity data, the overall presenting visual acuity of the better eye was an average of 20/70. The overall best corrected visual acuity of the better eye was 20/40. And this kind of makes sense that for those who are 65 or older, they tended to have a worse presenting visual acuity, and then also a worse best corrected visual acuity. And looking at the rural versus urban population, the difference between their presenting visual acuity was not statistically different, but the urban population did have a statistically better best corrected visual acuity. So that kind of makes sense that they were more, we saw they also had more refractive error in the urban population being the primary diagnosis. And it really didn't make a difference if they'd had a prior eye exam or not of what their best corrected visual acuity was. So just some of the conclusions from the survey. Most participants did endorse having a previous eye exam, but of those who stated prior eye treatment, only 43 stated that they could continue treatment. So there's some barriers to being able to continue eye care. And then refractive error presbyopia was the most common primary diagnosis. We did give, in the survey population, 111 of the 142 received a new glasses prescription or readers. And cataract was the second most common primary diagnosis. And then those in the rural areas were less likely to have refractive error as the primary diagnosis, and also tended to have worse best corrected visual acuity. So for doing our surgical outreach, I think focusing on the rural areas really makes a lot of sense. And that brings me to the next kind of destination, which after Peru, I traveled to Ecuador, to Guayaquil, Ecuador, and got to be there for a week with See International, and a lot of you know about See International. It's a nonprofit humanitarian organization that provides surgical care to underserved communities in the U.S. and internationally, and free of cost. And since being founded in 1974, See volunteers have completed over 500,000 surgeries in over 85 countries. And I got to go with Dr. Kinderman from Wills, and then also his friend, Dr. Jeremy Joseph from the UK. And it was the 3 of us as well as 2 nurses, and we had 5 OR days and did 135 M6 cases in those 5 days. And here's just a picture of the team on the left. And when we first got there, we saw all of the pre-op patients, and then had 5 days in the OR, and I really got to put to use what I had learned throughout the year and through India. So it was just great having this experience, and it was nice having Dr. Kinderman and Dr. Joseph right there in the same room. So if I needed their help or assistance, they were right there. So it was an incredible experience for me, and also just incredible to see how severe the cataracts were in this area, and the other doctors there had noticed a difference because they'd been coming, every year for the past few years with a break from COVID, and they really noticed that those 2 years without coming, the cataracts were just very severe. We saw a lot of patients with bilateral light perception vision from cataracts. So you really feel like making such a difference, kind of spending a week in a place like that. So I have 1 trip left to go. I'll be leaving next week to go to West Africa, to Sierra Leone. We'll be working with an ophthalmologist there who has been traveling to Africa for 30 years, and she and her husband founded an eye hospital in Sierra Leone. So it's going to be wonderful to get to go with them as my last trip before the end of fellowship. So just in conclusion, I just have this quote from Paul Farmer, who said, with rare exceptions, all of your most important achievements on this planet will come from working with others, or in a word, partnership. And this is really, I think, the most important lesson that I've learned this year is just forming partnerships and working with people all over the world. And we really all do have this common goal to eradicate treatable blindness. And so there are also so many people to thank for making this year possible. I especially want to thank the 2 guys in the middle there, Dr. John Anhold and Dr. Brent Finklea, and thank you, Brent, for this mustache in this photo. It's awesome. But my year would not be possible without the 2 of them. So just thank you so much for everything. And thank you.
All right. Thanks so much, Eliza, and great work. Our small, humble department really is built on the shoulders of our fellows, as they do really the lion's share of the labor. And we're so grateful for how hard she has worked this year and how many lives that she's touched. And with that, we're going to turn over to our resident presentations for the wire trip. I'm going to bring up Rakhi Melvani for the first talk on her trip to Kenya.
Thank you. My name's Rakhi Melvani. I'm one of the 3rd-year residents. Dr. Prajna, thank you so much for joining us. It's been really great to hear from you, and we appreciate you coming to teach us. Just a quick introduction to the WIRE program. The program was established in 2011. The goal was to provide ophthalmology residents with the exposure, training, and networking to become effective participants in fighting blindness across the developing world. It's generously supported by Wills Alumni Society, Wills Eye faculty, and our administration. Residents apply for a 1 or 2 week skills exchange in which they're exposed to challenges and rewards of working abroad. And over the past 8 years, we've sent over 40 residents to various countries as listed below. I had the opportunity to go for my senior wire trip to Tenwick Hospital in Bomet, Kenya. Kenya is located here on the map, and Bomet in particular is about 4 hours west of Nairobi, closer to the border of Tanzania. Bomet's a small county, and Tenwick Hospital serves a huge encatchment area with patients often traveling hours to days to reach the hospital for care. Tenwick Hospital and Eye Care Unit is one of the largest mission hospitals in Kenya. It was established in 1935, and it serves as a leading provider for primary care and advanced referral services. Bomet is a beautiful place, very green with these beautiful rolling hills. Tenwick Eye Center is extremely advanced thanks to the development of several attending physicians who've given their time and their effort there. Tenwick Eye has 3 wards, 1 pediatric, 1 women's, and 1 men's. Clinic occurs over the course of all 5 days, but Mondays are especially important. These are our admission days for admitting surgical cases, and the vast majority of the patients here necessitate admission since they're traveling from so far away and they need to be seen for their post-op day 1 visits. Cases are typically done from Tuesday through Thursday unless they're urgent, in which case they can be taken at any time, really, as long as staff is available. And in the clinic, there's about 7 clinical stations, and this is an example of what mine looked like. There's also basically any laser procedure or any diagnostic test you could want there. The Eye and Dental Center at this time is one of the most advanced facilities at Tenwick Hospital, and it sits at the top of the hill of the hospital. The clinic is truly an all-service clinic where patients can come and have all kinds of testing done and most subspecialty care. They're able to pick up prescriptions, and there's a pharmacy that's right down the hall and order glasses as needed. The OR consists of a pre-op area with 2 beds where patients from wards are walked down the hall to right before their case is set to be done so that they can undergo retrobulbar block by some of the nurses. The OR itself is one large U-shaped room, and there's 3 OR stations that can run simultaneously. All the PEDS cases typically go first in the morning with general anesthesia, and all other cases are done by retrobulbar block. This is a quick video of what the OR setup looks like. And then the left side is a picture of a brand new scope that happened to arrive while I was there. So Dr. Roberts and I had lots of fun putting it together. It was also interesting to learn how important it is to be able to assemble and troubleshoot your own equipment. And then, I was asked to touch on a couple important topics that we've discussed a lot of today already, but one of the important topics there is resident learning. These were essentially my co-residents at Tenwick. This is Japeth, who was a newly hired clinical officer, and then David, who was one of the rotating residents from Nairobi. And it was really great to have other learners there. We were often at each of the different stations and were able to see what cases were going on and sort of learn from all the different attendings all at once. So it was a very collaborative environment. I had the opportunity to staff my first globe with David, one of the residents. This was a patient who had come in from a trauma, who was monocular, and it was just great to have someone there with you to bounce ideas off of, and I think the end result was pretty good. Another important topic of global ophthalmology that, again, we've talked about today is the transfer of skills. And when we think of this, the top 2 that we think of are attending to resident, attending teaching resident, or an attending collaborating with another attending. But the other important ones to discuss are resident to resident. David and I had a really great time working with each other. And then resident to attending. Now, obviously, Dr. Roberts and the other attendings there, I learned so much from. They're so incredible in terms of their willingness to teach and their ability in teaching. But I had a handful of small, unique opportunities to teach things that I had learned from Will's from other attendings, like the enhanced dictasia display in an area where keratoconus is extremely prevalent, and of course setting up the surgical scope, which happens to be the same one that we use here at Will's. And a great example of skills transfer at Tenwick was the corneal transplant program, where our very own Dr. Hanish did a 2-week mini fellowship with Dr. Cropsey and Dr. Roberts, introducing corneal transplant to this region. And I happened to be lucky enough to be rotating at Tenwick while we received some donated tissue. And so we opened up the OR on a Friday and did about 9 or 10 grafts with that tissue. And another example of skills transfer, this is Dr. Mary. She's one of the most efficient, most brilliant M6 surgeons I think I'll ever meet. And as it turns out, she really wanted to learn how to phaco. And so the day after she taught me how to M6, I was teaching her how to phaco, and I had a whole new appreciation for what our attendings do here at Wills. It's a challenging thing to transfer. Lastly, I just wanted to say a huge thank you to Dr. Roberts and his wife, Jenny Roberts. I'm so grateful for the opportunity to work with you and to have learned from you, and I really appreciate your hospitality. I also want to thank all the other physicians I had an opportunity to work with, including Dr. Shule, Dr. Irene, Dr. Mary, my co-residents. Thank you to the Tenwick staff and the OR nurses for being so welcoming. Thanks to, this is sweet, Rugby Roberts, which a lot of the residents may or may not have met. He gets a little upset if you don't pet him, so And then a huge thanks to Dr. Finklea, Dr. Anhalt, Dr. Feldman for this incredible opportunity. Thanks to Dr. Kanessa, Dr. Diener, Dr. Matsunaga for these incredible accounts of your time there that were really helpful for me. Thanks to Dr. Hanish, who was like a dad to me, made sure he knew my location at all times. And Dr. Euler, who did the same thing. It wouldn't be a complete thank you without thanking my family, to my brother, my sister-in-law, and Michael for keeping an eye on my location at all times and making sure I was safe traveling. And then again, it really wouldn't be complete with thanking the two most important people in my life. This is my sweet dad, who's a general practitioner who spends every weekend working at a local food bank in our town, and this is him volunteering on Easter Sunday with the Easter Bunny. And then my mom, who grew up spending most of her 20s and early teens working in a home called the Little Sisters of the Poor in Chennai at an elderly home. And so it's just, I feel really grateful to have parents like this to look up to and try to live up to. Thank you.
Thanks so much, Rakhi. Because we have Dr. Hanush here, who's been really the father of this program from the residency side and working closely with Dr. Roberts for many years now, I just wanted to see if you wanted to offer a couple of comments on the program.
Thank you, Brent. So what's important about this is to share with everyone that the model we have at Tenwick is very different than the models we have with the WIRE program. So we started the WIRE program in 2011. It took a lot of negotiation with the church that controls Tenwick to convince them to have a secular program with Wills Eye Hospital that can be approved by the Dean of Jefferson. A lot of back and forth over many, many months, but we came up with a document that Tenwick was comfortable with and we were comfortable with, so that all residents from all faiths can go and have a great experience. This did not come easily. Ben Roberts is a retina-trained surgeon from Alabama who is devoting 25 years of his life to being there. Now, what's important about this is that when our residents go there, yes, Rakhi was very gracious in saying that she can transfer knowledge to the attendings there, and certainly she did that to one of our colleagues in Kenya. But basically, Ben Roberts is a superb surgeon who can do just about anything, but there is still a need. So he does retina, obviously, does cataracts, M6 and phaco, tubes patients. I mean, he is truly the quintessential ophthalmologist who can do it all. Now, we cannot continue this relationship without us trying to transfer new knowledge to him and to Georg Schule, who's from Germany, and some others who volunteer over there. This is not like the other places we go where the recipient hospital that has attendings there, like in India, like in Haiti, like in other places, where our residents are being trained by the local surgeons. Here, Ben Roberts is there, but he needs us to reciprocate to him. So the only way we can do that is to have us send our doctors to Tenwick. So this year I'm going for my 5th time after John Cropsey, class of 2009, convinced me to go in 2010, where we started the corneal transplant program. But there is a need. Chris Rapuano has been there. Some other doctors from other hospitals in the U.S. have been there. The biggest need right now is oculoplastics, followed by oncology, followed by Julia. Retina is needed also, but the truth is, as you know Ben very well. He is a superb vitreoretinal surgeon. You can leave. But anyways, so I'd like to encourage our faculty to consider going there. All the specialty services are welcome. The biggest need is plastics. If you would consider possibly going there, it's a great experience. You can take a young child or adolescent child with you. They will have an incomparable experience. It includes going on safari at a 70% discount at one of the high-end safaris in Africa. People who volunteer at Tenwek are given a huge discount when they go on safari. So think of it, 7,000 miles away, so it's far away, but it's an unmatchable experience. And thank you for listening. Thank you, Brent.
Excellent. Thanks so much, Sudhir, for those comments. And for our last quick talk, I'm going to have Ollya Formal come up and talk about a new site that we are engaging with some other physicians from the Philadelphia area and some of our subspecialists here from Wills Eye, and share about her experience in Morocco. Ollya.
Good evening, everyone. My name is Ollya Formal. I'm a senior resident here at Wills. Before we begin, Dr. Prajna, thank you so much for coming. The lunch today was a treat. Just thank you for sharing all your wisdom with you. You're just so inspirational, and your kind of motto, you're, like you mentioned, a business of service, kind of really resonated with me and the whole point of the Wire trip and global ophthalmology. So they are inspired by everything you do, and no doubt that's why you're so successful, because your heart is at the center of everything you do. So thank you. So Mission Morocco, this was an incredible opportunity and the first ever, as you later see, international eye mission trip to that country. But before I begin, I have no financial disclosures to report, and just a little bit about a background about the Kingdom of Morocco and why we were there in the first place. So Morocco is located in the northwest portion of Africa in the Maghreb region. It's surrounded by Atlantic Ocean on the west and Mediterranean Sea in the north. It's a population of around 33 million people. It's largely been influenced by Arabic cultures, Amazigh or Berber cultures, as well as strong French influences, and which is reflected that most of the national education is performed in French. There are also many dialects, too many to count. The poverty rate there is over 30%, and about a third of the population are illiterate. So the country faces great challenges with regard to access to care. There's about only one doctor per 2,000 inhabitants, and very limited access to poor, and especially for rural populations that live far in the Atlas Mountains. The health ministry budget is only 5% of gross domestic product. Infant and maternal mortality rates are very high. World Health Organization places Morocco as one of 57 countries that have experienced an acute shortage of healthcare workers and thus unable to provide vital resources due to lack of resources. So what does the burden of eye disease look like in Morocco? There's about over 1.5 million people who have significant visual impairment. And this infographic was taken from the International Agency of Prevention of Blindness and just compares Morocco to United States and Kenya. And as you can see, the crude prevalence of blindness and severe visual impairment is significant as compared to the United States and even Kenya. So age-related cataract is the most important cause of blindness and bilateral poor vision loss. And there is just an astounding need for cataract surgery with over 500,000 eyes that are in backlog in about a 250,000 people. And we are, according to C International, are the first international mission to Morocco. So this is our team. We couldn't include everyone, but I just want to tell you a little bit of a story how this trip came about. And I have to mention Dr. George Prenesti, who is a senior partner at the Kremer Eye Institute. He went on vacation to Morocco about 2 years ago, where he met Rashid, a local tour guide who came from the Atlas Mountain, and he took him to his home in the mountains. And there, Dr. Prenesti was faced with that. With the need of so many people suffering from visual impairment. And he vowed that he would come back, and it took him 2 years and persistence and dedication to make that come true. So he partnered with Aziz, who is the executive director of the Volunteer Morocco. It's an organization that brings health students and health professionals from the United States to volunteer in Morocco. So Aziz had a strong connection in local government and agency and Ministry of Health, who also introduced us to Dr. Jawad Mahmoud, pictured here as well, who is an owner of a very successful cataract clinic in Agadir region, who was so generous as to offer his clinic for to our disposal for a week, and also introduced us to this gentleman, who is Omer Mustaine. He is a department chair of ophthalmology at the local hospital, Susmasa Hospital, who, and the timing couldn't have been perfect because a year prior, they've started first ever ophthalmologic residency in Agadir. So we had the opportunity to work with many residents during our trip there. And Dr. Mustaine introduced us to the only the transplant surgeon in Morocco from Rahat, who generously offered his mobile surgical units to be at our disposal as well for the duration of the trip. So there's many people involved, too many to thank, but the key to any successful operation, as we've heard over and over today, is like strong partnership with local government to ensure sustainability. This is our team, and we call it the Dream Team. So this is Hannah Cole, who is nurse and scrub tech, Justin Prenesti, a son of George Prenesti, who was there for anything that we needed. Dr. Reza, who did glaucoma surgery and cataract surgery. Then this is Aziz, who I mentioned, from Volunteer Morocco. Dr. William McCollum, he is a cataract, glaucoma, and surgeon from Dominican Republic. He's also the director of residency program in Dominican Republic. Dr. Neil Feldman, who is a cornea specialist from Kremer Eye Center, and as we know, Dr. Ayan Chatterjee, who recruited me for the trip, who's a glaucoma and cataract surgeon and Kremer Eye as well. And I could mention our two scrub techs, Danae, who we all know and love, and Tasha from Kremer Eye as well. So our goals were threefold. The first was to answer that first original question, and to provide care to the people of the Atlas Mountains, 8 Bugamez Valley. And second was to provide the surgical services, cataract surgery, glaucoma surgery, and oculoplastic surgery. And in the previous slide, one person missing was Dr. Yuri Bilik, who performed the orbital surgery. And here's the picture of him, which is the third goal, was teaching residents, local physicians, nurses, and technicians. As I mentioned, there were 3 main sites that we worked at. The first one was the mobile surgical units, where I was mainly stationed, and this picture was taken after a very, very long day of cataract surgery. One of the probably best experiences I've had there, and I'll tell you a little bit more about it later. The second was the private clinic, as I mentioned, that was generously offered to us by Dr. Jawad Mahfoud. And third was the local SOS Masa hospital, and residents were able to rotate with us through each of the sites. So I'll focus mainly on the mobile surgical units, and here's the picture representing our typical setup. The units, the trucks were stationed in the city of the Agadir, and you might note a fence here is because the word quickly spread out that there were surgeons coming to the country, and people were coming by dozens each day trying to seek care. Here's our little check-in area. We did a screening for cataract surgery at the same place, and then when patients were moved to be screened further and to have the surgery in the mobile units pictured here. So this is me operating with Dr. Reza here. This is a typical setup. We had different machines. This one features Centurion, but also older versions were available as well. And the second, this is a more of surrounding area around the trucks. Just shows how many people were coming to the surgical sites, and thus us staying very late nights and trying to help as many as we could while we were there. The second side was the private clinic, and this is the director of the clinic. As I mentioned before, without whose generous donation, this trip would not be possible. And this is residents and Dr. Pranesti performing surgery, setting up for surgery and further training here. And then the third site was the SOS Masa University Hospital, and this is Dr. Billick with a resident and a healthy patient, and it's him performing surgery, oculoplastic surgery. So as I mentioned, the major focus of our trip was resident education and medical education. We have performed numerous conferences, and this is a resident case presentations. Dr. Feldman was talking about refractive surgery, and here we're reviewing some imaging. We also participated in grand rounds. As you can see, Dr. Billick here, cases were presented to him, and he is engaged in a lively discussion with the residents. Here's Dr. Reza enjoying some afternoon delights with one of the local officials. And this is him presenting on how to manage complex cataract cases. And this is Dr. Feldman. He taught the first keratoplasty course in Agadir, which was later followed by a workshop. And this is Rashid, as I mentioned him previously. He was the original tour guide that connected with Dr. Pranesti, and he was the one who went to the remote villages in the Atlas Mountains, and he said, I can take 2 people from your village to come with me to Agadir. And so he would drive all night hours to bring those patients, and many have walked prior to that to see him as well. And I have a quick video to show you. It's my brief interview with him. Hi, we're here in Agadir, and I'm here with Rashid. Rashid, do you mind introducing yourself?
Yes, of course. So my name is Rashid. I come from the Atlas Mountains of Morocco. I live in Gugmaz Valley. I'm actually a professional driver in tourism. So we are here today to help poor people. They are suffering in their eyes. So to get the surgeries with doctors, coming from America like Ollya, you guys are doing an amazing job.
Thank you. Tell me a little about the valley and the villages there and how you selected people to come to our clinics.
So in this valley called like Bugmaz Valley, we don't have a doctor of the eye. So we don't have doctors. People are poor in the Atlas Mountains. They are shepherd and the nomad. They live in the caves. They live over the mountains. So they don't get the access to go to the hospital. in no hospital, actually, like a private hospital or a doctor, they can treat their eyes, but also it's very hard to travel far away to get to the hospital in Benilde or Casablanca, it's too far. So they are very happy that this opportunity, to get this opportunity that you offer, guys, so thank you so much.
And tell me, how many villages are there, and how did you select the patients?
Okay, so in our valley there are over 20 villages. 27 villages in Akbukmas Valley. So we selected like 2 patients from each village. 2 patients from each village because Agadir, as you know, it's very far, almost 9 hours drive. And the people are old, so it's very hard to drive in from mountains, the off-roads and the zigzag mountains, so it's very hard to make it here. But some of them, get here, like my, grandmother, she is almost over 100 years old, and other people from other villages, 90 years old, so they are doing amazing, they are much better now, they can already see, so they get the surgery here, and they are very happy, they are proud of you guys, and they are thanking you so much.
And what would you like to say to people in America for next year?
Okay, so in America, inshallah, so I'm just, I want to see that, first of all, thank you, and thank you for everybody who is supporting this idea, of helping poor people and volunteering also in Morocco. I love volunteering, and also I'm supporting this idea. I'm helping and supporting too. So anyone can come and help these poor people. They are really in need. They are really in need. They are poor and they cannot go to other places, so they are really in need. So I am hoping a lot of doctors can, because there were a lot of patients, and you will 5 or 6 doctors, then you cannot make everyone, have the surgery. So I hope a lot of other doctors will come with you, and maybe nurses to help you also in the mountains, because there are plenty. And I'm expecting, the valley of Zawit Ahansar and Energy and Ait Abdi also.
How many people live there?
So I don't have exactly the number, but in Zawit Ahansar, a lot of, like 1,000 something. I'm not sure, but this is just, you have to expect hundreds of people will come. Next year, coming from Zawit Ahansar, Ait Abdi, Energy, and also Ait Bugmas. This is like the high class, like 2,000 and 2,500 meters high above the sea, right? So it's very high. So they will, inshallah, come to the valley next year to meet you, and they will be happy too, inshallah, to meet you.
Inshallah. Thank you so much for everything that you've done.
My pleasure. That's my pleasure.
Them and driving them in the morning, and then driving them back hours and hours. And
thank you, doctor. Thank you, doctor. Thank you, doctor. Thank you. Bye.
Rashid is very humble. He put in so many hours of work to bring these people, and this is just pictures of the mountains and where the people live. And just to emphasize, these people would otherwise will not get access to care, and this in no way undercuts the local business. And the clinicians in Agadir were so thankful that we were coming and supporting this community. And just some of the results, the surgical impact, we were able to do 253 cataract surgeries just in the short time that we were there, 14 glaucoma procedures, 10 orbital palpebral surgeries, 9 refractive surgeries, and the training impact, numerous academic conferences, keratoplasty workshop, 16 physician residents that were trained, and over 20 nurses and technicians that were trained as well. And many more have attended our conferences. And Rashid was sharing just recently that how happy people were. Many of them for the first time were able to see their relatives, and just looking forward to seeing us again next year. And so, lesson learned, I was so fortunate to be there at the beginning of this submission. So to see it from its inception, to figure out how do we organize it, how do we screen the patients, and just the logistical side of that. This is me. I don't speak Arabic or French, so writing down some words to communicate with patients. It was funny, the first day I've learned how to say, open your eyes, don't move, look down, and the next day nobody could understand me. And what I learned, that I've learned to say that in Amazigh or in Berber language, language, but then because that's where the patients from the mountains, but the following day the patients were coming from the Agadir, so they spoke the Moroccan Arabic. So I had to learn that as well. And just adapting to the environment, to not having your Dr. Bleacher's settings with you and using whatever the attendings have, and not having a bleacher chopper by your side as well. And just working what resources that you have. And learning, had the honor of being a scrub tech for Dr. Reza, who was so patient with me, learning how to set up machine, how to circulate, which is invaluable skills. We also found that they only have 0.5% tropicamide, so all of the pupils were 4 millimeters. So next year we'll definitely bring cyclogel and phenylephrine, but we'll learn how to make our own sugar cane. So if anybody runs low, I can teach you how to do that. And just the best part is just learning about their culture, interacting with patients. And this was a very special patient to me who had significant visual impairment bilateral. And as I was removing the drape, he was mumbling something under the breath, and I was worried because the translator was not there and was saying, was he in pain? Because this was just drop-only cataract surgery without a block or anesthesia. And then when he was setting up, he was saying, shukran, shukran, shukran. It means thank you, thank you, thank you. And it's difficult when you can't help those hundreds gathered outside your door, but for him, we made all the difference in the world. So I couldn't be here without Brent Finklea, so thank you for taking me on my offer to go to Morocco, and thank you, Dr. Chatterjee, for inviting me and sponsoring my trip. Thank you, Dr. McCollum, who was my main surgical mentor, and Dr. Pranesti for organizing the trip, and Hannah, who was with me every day. Also, this is the department director of the ophthalmology at the local hospital and director of the clinic, Danay, as we know, all in love. And this is Rashid, and this is Aziz, the director of Volunteer Morocco. And this is our little Wills team in Morocco. So next year, join me. Thank you very much.
So thanks so much, Ollya, for that presentation, and also for all the physicians who contributed, Dr. Chatterjee, Drs. Billick, and Reza as well, for your hard work. As we talked about, these endeavors always begin with relationships, and the projects really flourish from then. So with this as a new endeavor, I look forward to seeing where it goes in years to come. So I'm actually going to switch over the mic to John Anhold, and we've got a couple final thank yous for Dr. Prajna.
Of course. Let me join the long list. Everyone ahead of me, thank you so much for taking the time to do this out of your busy schedule, the travel to take these hours and share with us your experience from your pivotal role in the leadership of Arabian healthcare system. Our fellows get the opportunity to go there. Historically, myself, I got to meet you about 3 years ago. And along with you and Dr. Sankov Singh, I had an incredible experience getting to explore the system. And I took home from that so much more than I was able to give at that time. But hopefully, over the last couple of days, we've been able to extend to you even a fraction of the hospitality that you were able to show us over the years. And so with that, we'd like to give you a few parting gifts.
Please come on up.
As is tradition.
Yes, absolutely. The illustrious Will's eye tie, of course. Absolutely. We have to, of course, provide always a copy of the Will's Eye Manual for your residents. So I think you've written everything already that's in this, but you can share with them, and then, of course, your name's on.
And of course,
just a symbol of our gratitude for the time you've taken for us all here. So thanks so much for joining.